past noon, so in the interest of time, we're getting started. So I would like to welcome all you to this very special webinar in honor of Menopause Awareness Month, which is titled "You're So Hot Right Now: Navigating Perimenopause, Menopause, and Beyond," and it's hosted by Stanford Alumni Association and Stanford Healthcare. I'm Christina Galloway with Stanford Healthcare, and I'm happy to be spending this lunchtime with you all, listening to information on such an important topic. Before I introduce our lovely menopause specialist, I do have a few housekeeping items. This webinar is being recorded, and we'll share out a link following the presentation. It's roughly 45 minute presentation followed by 15 minutes at the end for Q&A. If there's a question, please type it in the Q&A chat at any time. The last 15 minutes I'll spend with Dr. Adams reading through the submitted questions, and we'll do our best to go through as many questions and topics as possible. At the end of the webinar, we would love to hear from you all on the presentation, so we encourage you to please complete the questionnaire. Now, I'm thrilled to introduce Dr. Karen Adams, a distinguished expert in women's health. Dr. Adams is doubly board certified in OB/GYN and lifestyle medicine, and she is a certified menopause specialist recognized by the Menopause Society. As a clinical professor at Stanford University, she leads the Stanford program in menopause and healthy aging, and is a faculty affiliate of the Stanford Center for Longevity. With over 30 years of experience, Dr. Adams specializes in menopause management and female sexual dysfunction, focusing on lifestyle medicine to mitigate aging-related chronic conditions. Her work reflects her unwavering commitment to advancing women's health. Today, we are fortunate enough to have her share her insights and expertise with us. So please join me in welcoming Dr. Karen Adams.
Thank you so much. Let me make sure I'm not muted. Okay. I always feel like the content, the medical care is not difficult, but the technology is always difficult for me. So I appreciate the opportunity to be with you. I am thrilled that we have World Menopause Day on October 18th. This year, the topic was lifestyle medicine, which is super important in midlife and healthy aging. And then to have an actual menopause month is even beyond the beyond. So I'm happy to be here to mark that important milestone in life. And for all of us, really, I mean, it's not just if you have ovaries, you're going to go through this. Everyone is affected by it because everyone, if you don't own ovaries, you still love someone who does. And so whether it's you or whether it's a loved one, menopause affects everyone. So I'm really happy to be here to share this hour with you. And if I end up speaking less than 45 minutes, then we'll have more time for questions. So that's all good. So here are my slides. Can you see them, Christina? Just nod or thumbs up. Okay. All right. So you're so hot right now. And I titled it Navigating Perimenopause and Menopause. And you'll see why in just a moment, why those are two very distinct and important things. To begin with definitions, menopause, the definition of menopause is no period for 12 months. So we only know that in the rear view mirror, right? You don't know when you're having that last period until 12 months later, you're like, well, gosh, I guess that was it. So it's a retrospective diagnosis. It's in the rearview mirror. But when you haven't had a period for 12 months, that's formally, officially menopause. And then after that, the whole rest of your life, you are in post-menopause. On average, in the US, this happens around age 51, but it can be quite a bit earlier than that or quite a bit later than that. Important to know that at this point, you can no longer get pregnant, but up until that point, you certainly can. And up until the point of that final menstrual period, the years leading up to that, we call the perimenopause. On average, that lasts 4 to 8 years, but can range from 1 to 10 years. So even people in their early 40s might be starting to have some of the symptoms of perimenopause. So symptoms start in the perimenopause, and people can still get pregnant during that time. So it's an important thing to be thinking about, unless, because if you don't want to get pregnant, you need to be thinking about contraception all the way up until that final menstrual period. Now, what is going on in perimenopause and menopause? I always show this slide because it's about the physiology of it. And when you understand the physiology, all the symptoms and everything makes so much more sense. So, when you have a period every month, what that tells us, what that tells you, and what that tells me is that your brain is talking to your ovaries every month, and it's sending a signal every month, and the ovary is responding every month. And it's consistent, it's reliable. Your estrogen goes up, comes down, you ovulate, your progesterone goes up, comes down, you have a period. The whole thing starts over again every month. It's predictable and cyclic. What happens in perimenopause is your brain is still sending that signal to the ovary the way it always has. Every month it's talking to the ovary, but the ovary is aging. And so the ovary responds less and less consistently to those brain signals. It basically just kind of sits back and goes, yeah, no, not doing it, not responding. And then it just wakes up. And then you have this big surge of hormones, and then it goes back. And so it's completely unpredictable. That's the point. Prior to perimenopause, it's predictable. But in perimenopause, it's unpredictable. And all your symptoms become unpredictable as well. Your mood, your sleep, your sex drive, your hot flushes, your periods, everything becomes unpredictable. That's why perimenopause is so challenging. And so we always think, caution, caution, stormy seas of menopause ahead. Really, what we should say is caution the stormy seas of perimenopause, because that's when things start to go south. And for those of you who are sort of visual learners like I am, I like this picture so much because it really does show in visual representation what I just explained. So you look at the premenopause section, and yeah, there's a lot of ups and downs, right? But it's predictable, it's cyclic, it's regular. So at least with PMS, you can say, look, it's the week before my period. I know I'm going to feel crummy, and it's predictable. But look what happens in perimenopause. Everything gets dysregulated, right? It's wacky. There's no rhyme or reason. And these are all different hormone levels here with the different lines, but you can tell there's just no predictable nature to this at all. Post menopause, everything is stable. Nothing's going up, nothing's going down, everything is stable. But in perimenopause, everything is very unpredictable. This is why hormone levels do not help us to diagnose what's going on in either perimenopause or postmenopause. People come into me all the time and they say they want their hormone levels checked. But if you think about it, and look at this in perimenopause. I can check your hormone levels every week for 6 weeks or 10 weeks. They're going to be up, they're going to be down, they're going to be all over the place. So it really doesn't tell me anything that your symptoms aren't already telling me. And then in postmenopause, I don't need to check your hormones because I know what they're going to be. They're stable all the time. So that's why blood levels don't really help us when we're trying to figure out what to do for symptoms. Okay, so your periods change for sure because the ovary is responding less frequently. So skipping periods is really normal in perimenopause. It's normal to go a couple months without a period and then maybe have it start up again. What's not necessarily normal is spotting all over the place, spotting, just randomly and frequently, or periods happening more frequently. If you're having them all of a sudden every other week, that's not normal. If you're having really gushy, heavy, prolonged periods, 14 days, lots of flow, lots of clots, that's not normal. So make sure that you check in with a provider if you're having these kind of atypical periods. Okay, I'm skipping periods. Okay, fine. What else? What else happens in perimenopause? Well, this is when everything kind of kicks in. So this is when people start having hot flushes and night sweats. They start having sleep disruption, mood disruption, vaginal changes, joint pain, brain fog, that sort of, gosh, that word is just right on the tip of my tongue. That happens in perimenopause, and a wide range of other kind of symptoms. Palpitations, you can get heart palpitations, you can get changes with your hair or your skin or your nails, you can gain weight. We'll talk about some of these in a minute. The reason that I listed all of the sleep, mood, um, kind of right up there with hot flushes and night sweats is that they are really common and they are very disruptive. And so we will talk about that. The important thing to know, as this is starting to sound very depressing, I want you to know that all the symptoms are 100% treatable. We always want to be thinking about behavioral and lifestyle approaches. As Christina was saying, I'm board certified in lifestyle medicine as well as in menopause. And so all my patients get exercise and nutrition prescriptions, and because it really does make a difference in this period of time. And then we have medication that we can use, either hormonal therapy or non-hormonal. So it's always kind of a multi-pronged approach, not just one size fits all. If I had one lifestyle thing that I could package and put into a prescription, a pill, it would be this. It would be exercise. Exercise helps everything, always. It will help everything. It helps your sleep. It helps your mood. It helps your sex drive. It helps your menopausal symptoms. So there are 4 different components of exercise that we always need to be thinking about. There's, of course, the really important aerobic exercise, which exercises our heart. And that's really anything that gets your heart rate up a little bit. So walking is aerobic, but you want to be doing enough of it that you're getting your heart rate up a little, you're breathing a little bit heavy. So pushing it a little bit, not gasping for breath, but just, breathing heavy. So walking, jogging, tennis, swimming, anything that gets your heart rate up is aerobic. Strength training is super important. You want to be doing 150 minutes of aerobic activity each week, but at least 2 to 3 episodes of strength or resistance training each week. So I'll say that again. 150 minutes of aerobic activity each week. You can do it all on the weekend, or you can divide it up 20, 25 minutes each day. But your target is 150 minutes of aerobics plus at least 2 episodes of strength training. Now, yoga and Pilates and things like that are wonderful for core and balance, but they don't count as resistance training. You really have to lift weights or pull those resistance bands or do actual push-ups, sit-ups, push-pulls, those sorts of things. That's what strength training is. Flexibility becomes more and more important as we age, to decrease our fall risk and to keep us mobile. So we always want to be doing stretches, things like pulling your knee up to your chest or cat-cow stretches. And then the other component of exercise is balance. Again, super important for healthy aging. Try brushing your teeth every day, standing on one foot. Just try that. Try when you're brushing your teeth to stand on one foot. It's hard. And you realize how balance is starting to go as you age. So doing those one leg stands, doing those yoga poses. Tai Chi is wonderful for balance. Dancing hits both the aerobics and the balance. So you really want to be cross-training in all these areas. Every system in the body is improved by physical activity at any body weight. Don't let perfection trip you up. Just go outside and walk. You don't have to do anything fancy. Just anything you do gives you benefits. And so here are those simple rules. These are from the Department of Health and Human Services. You want to do at least 150 minutes of aerobic activity each week, plus at least 2 days of muscle strengthening, and then mixing in flexibility and balance. So that's your exercise prescription. The nutrition prescription is this, that you mostly eat plants. So you think about your plate, 50% of it, fruits and vegetables, always. Every time you sit down for a meal, half of it should be plant-based fruits and vegetables. A quarter of it would be whole grains, and that's whole wheat pasta, brown rice, oatmeal, things like that. Try to avoid white flour, white pasta, white bread. And then the other quarter is protein, ideally plant-based protein, but if you're going to eat meat, white protein. So that would be chicken and fish. So that's really kind of a Mediterranean diet approach. And this is going to be very helpful for mitigating that midlife weight gain that we all see. All right. Well, 80% of us get hot flushes. So what do we know about hot flushes and night sweats in menopause? Number one, we know that they start early. So if you look at the age here on the far left column, we're talking relatively young women in early perimenopause, 45 to 47. Almost more than half of those folks are flashing. 80% are going to be flashing by the time we're into our late 40s. And sometimes these people haven't even really changed their periods yet. And so docs and providers will sometimes say to people, this can't be about perimenopause or hormonal because you're still having periods. That is not true. You can still be having periods and be hot flushing. And even after 55 and beyond, 75% of people are hot flushing still. So this is the most common symptom that people get. Severe hot flushes vary according to race and ethnicity. This is, I think, very interesting. It comes from a big study that was called the Study of Women's Health Across the Nation, or SWAN. And what we found from this study is that our Black patients, friends, colleagues, are hot flushing longer, more severely. 50% almost are having severe hot flushes for almost 10 years. And then Hispanic folks are a close second to about a third of them, a little more than a third, almost as long for almost 9 years. Caucasians are kind of in the middle. Chinese and Japanese a little bit lower than average, and that's interesting. We're not really sure why that is. It could be genetic, it could be environmental. We don't really know. But people's experience of hot flushes vary according to race and ethnicity. So this is what we usually do. For people who are candidates for hormone therapy, we used to call it HRT. We now call it menopausal hormone therapy, or MHT. We usually do an estrogen patch plus a progesterone pill. Or we do an estrogen patch alone if you've had a hysterectomy. If you have a uterus, you need both the estrogen and the progesterone. But if you have had a hysterectomy, all you need is the estrogen. And we like a patch, a skin patch, rather than a pill, because if you swallow an estrogen pill, it increases the risk of a blood clot, just a little bit, not a whole lot, but enough that we try to avoid the pill and we do the patch instead. And with this, usually people's hot flushes are gone within 3 to 4 weeks. And so it's really quite a relief to have things better so quickly. And ideally, we want to start this hormone plan within 10 years of your last period, whatever age that might be, or under age 60, because that's the window of time that you really get the benefits. In general, who should not take hormone therapy? There are a few groups of people that we really recommend against it, and that is people who have breast cancer themselves, not a family history of breast cancer, but if you have breast cancer yourself, we generally avoid hormone therapy. If you've had a history of a blood clot in your leg or your lung or your brain, if you've had a heart attack or a stroke, or what we call a TIA, a transient ischemic event in the brain, or if you have really active hepatitis or other kinds of liver diseases or active gallbladder disease. Those are in general the big categories of people who should not take hormones. Family history of these things is not a contraindication. Even if you have a BRCA gene or something that increases your risk, that does not mean you cannot take hormones. And so it's definitely a risk-benefit discussion that you should have with a provider. If you fall into those categories, we do have some really good non-hormonal treatment options that are not estrogen or progesterone. In particular, fezolinetant is a great drug that came out a couple years ago. There's a lot of ads for it on TV. It's also called Veoza. That's the trade name. It's a single pill that you take every day. It's not hormonal. It works on the brain in a different place than the estrogen receptors, and you get a really good benefit from it in a couple of weeks. Hot flushes decrease by 60% or more. So it's a single tablet. It's a great alternative for people who can't take hormones. Antidepressants, things like Prozac, Paxil, Zoloft, things like that, are good for treating hot flushes, but they do tend to have a lot of sexual side effects, so that limits their use. Gabapentin is an interesting drug that you can take at night, and it will improve both sleep and hot flushes. So don't despair if you're symptomatic and you can't take hormones. You have some good options, again, worth discussing with your provider. What about all that stuff that you can buy over the counter? What about Women's Formula 1 or Women's Formula 2 or Black Cohosh or Dong Quai or Red Clover? None of those have been shown to be more effective than placebo. So sadly, no, they don't work, and they just cost money. And in fact, they can cause liver abnormalities. So you want to be really careful about assuming just because you can pick something up off the shelf at Walgreens that it's safe. That doesn't necessarily mean that it is safe. Okay, when you talk to women or people with ovaries about the bothersome symptoms of perimenopause and menopause, in general, the sleep disturbance disturbs them more than the hot flushes. That when you're not sleeping well, oh my goodness, everything can be affected. So, sleep hygiene is super important. We need to be thinking about ways that we can promote good sleep. So you want to have your wake up and go to bed routine. You go to bed and you wake up at the same time every day, even if it's a weekend, even if it's a holiday, unless you're sleeping well. If you're sleeping well, I don't care. Sleep until 10 a.m. on the weekend. That's fine. But if you're struggling with sleep, try to be consistent with your wake up and going to bed. Avoid blue light, i.e., screens. Avoid screens at night. They hit your brain. They tell your brain it's time to wake up. Don't eat or drink before bed, ideally 2 or 3 hours before bed, especially alcohol and caffeine. Really try to minimize that. Dark, cool, cozy environment, turn the thermostat down, get really fuzzy blankets and all that. And try to pay attention to your exercise goals and your whole food plant diet. That will help with good sleep. Try not to do really vigorous exercise within 2 hours of sleep. But if you're going to do your flexibility stretches, that's perfect right before you go to bed. So this is all super important, but I talk with people about this, and when they really have sleep disturbance, they say, I am doing all that, but I'm still not sleeping. And that's really true. That can be true for people. So what determines if somebody really has a sleep disorder? Well, we think it's normal to wake up twice a night to pee, basically. So if you're waking up, you pee, you get back in bed. The question is, then what happens? Can you fall back to sleep within 15 or 20 minutes, or are you laying there then for 2 hours? That's what determines whether or not you have true insomnia. So if you get up, you pee, you get back in bed, you fall back to sleep, that's normal. But if you can't fall asleep, or
I'm
if
working
you
with her on this
or if
program.
you wake up,
She's the coolest.
How many people you got on there?
400.
somebody is not muted. So if you're waking up, but then you're awake for 2 hours, and then that's happening at least a couple times a week, and you're having distress or difficulty during the day because of it, that's true insomnia. So if that's your situation, then that's really something that needs to get addressed. And look at this. This really happens to us in perimenopause and postmenopause. If you look at this gray bar, it's difficulty maintaining sleep. So most of my patients tell me, yeah, I can usually fall asleep, but I wake up at 2 a.m. and then I can't go back to sleep. And that's what this difficulty maintaining sleep is. And you see that 30% of folks have that prior to perimenopause, but it goes up to 50% in perimenopause, and then it kind of sticks around afterwards in postmenopause. So this is really common for women in perimenopause, and hormone therapy really helps with this. Estrogen takes away the night sweats, which will wake people up, and progesterone actually hits the sleep centers of the brain, and it helps you sleep. So hormone therapy is very effective for this. The other thing that's very effective is a thing called cognitive behavior therapy for insomnia, or CBTI. It's kind of paired with mindfulness-based strategies. And people often are like, I really, I don't think this is going to work. It actually really does. It's more effective than Ambien or Trazodone or Benadryl or magnesium or melatonin or anything. So CBTI is a super powerful way to manage when you wake up. The thing is, everybody wakes up, but when you wake up, often what keeps you awake is what then starts happening in your brain. And so the CBTI helps you to treat being awake a little differently. And you can learn to say things to yourself like, I'm not going to try to solve my problems right now. This isn't my good brain right now. Also, it tells you things like, even if I wake up tired, I still get it done. I can get it done tomorrow regardless. And so CBTI can be super helpful. And we have a great sleep program at Stanford where I refer people to a lot. The other thing I wanted to kind of spend a little time on is mood changes, because that's also very, very common in perimenopause. More than half of women, of people with ovaries, will experience mood issues in the perimenopause. Most of the time, it's more irritability and anxiety than it is true depression. But women who do have a history of major depression in the past are more at risk for this. So if you had depression in college, or if you had postpartum depression, you're a little more at risk for this around the time of perimenopause and menopause. And up to 65 to 70% of women of people with ovaries, get what we call perimenopausal mood instability, or PMI. It is more common than PMS, but no one's ever heard of it, right? I mean, we all know what PMS is. We have heard of it, we talk about it, we know what it is. PMI is more common than PMS. And the problem with it, the reason it's so challenging, is because you never know from day to day how you're going to feel. Some days you wake up, you feel good. Other days you wake up, you don't feel good. And it's because of that crazy hormone shifting that I showed you at the beginning of the talk, is your hormones are so out of balance and all up and down that your symptoms are unpredictable too. This is why this is so hard for folks, because it really varies from day to day. The other thing is that we're dealing with so many life stressors in the perimenopause and menopause, because, our parents are aging, our children are going off to college, we're kind of hitting our stride at work, and we've got a lot more responsibility. So there's just a lot going on that trigger anxiety and mood issues in this time of life anyway. So always, always, always go on an antidepressant if you need it. If you have major depression and you've had it in the past and it's coming up again, treat it with antidepressants for sure. But estrogen helps. Estrogen stabilizes mood swings, helps with the tearfulness, the irritability, feelings of sadness. Other things to help with mood stabilization, relaxation, stress reduction techniques, doing things to kind of get you out of your head. This is called, the lifestyle medicine people call it enjoyable recreational activities or something like that. We just call it hobbies. So, pick up your musical instrument, or go out and find a place where you can go dancing. Those kinds of things really help with mood stabilization. Exercise is very beneficial for mood, and being in nature gets our moods elevated. Particularly, it's interesting, the research about being in nature and mood is that blue and green environments tend to really promote mood. So find yourself some grass, find a forest, or find an ocean. Something blue or green will hit the ruminating center of your brain and improve your mood. But it's not just symptoms, it's long-term health too. And women come in, people with ovaries come in, and they want to know, how is being on hormones going to help my heart or my bone or my bones or my brain and my breasts? So let's talk about that. So when you go through menopause, you're going to have some negative impact on your total cholesterol, on your LDL, on your blood pressure. So at any age, whatever age you go through menopause, your blood pressure is going to go up a little bit. Your total cholesterol, your LDL, is going to go up a little bit. And this just happens not because of hormone therapy, but because of menopause. And it increases our risk for cardiovascular disease. Here again, for the visual learners, like I am, is a picture of how lipids are impacted by hormone therapy. So across the top, we've got our HDL, the good cholesterol, the LDL, the bad cholesterol. We have triglycerides and total cholesterol. And on the left side, you can see the difference between oral estrogen and the patch. And you see most of the time we're using the patch. And you can see with the patch across the board, it's either neutral or positive. So your cholesterol is not going to take a hit because you start hormone therapy. It will take a hit because of being in menopause, but hormone therapy doesn't make it worse, and in some conditions, it makes it better. Oral estrogen bumps triglycerides. It makes your triglycerides go up. So another reason why we try to avoid oral estrogen. We also gain weight in midlife. Unfortunately, you eat the same, you exercise the same, you gain weight, and it settles right around your belly. And people think that, they think they're losing their mind. They're not losing your mind. This happens. It's metabolic, it's physiologic. It's related to aging rather than menopause. We lose our muscle mass, we lose our metabolic rate, it slows down. Resting and active metabolic rate slows as we age. And in general, in menopause, you eat the same, you exercise the same, you're going to gain about 1.5 pounds to 2 pounds a year. And some people will gain more than that, quite a bit more than that. This is also due to other things, life stressors, not sleeping well. It's harder to maintain your weight if you're not sleeping well. It's related to low mood. It's related to, every time I try to exercise, I hot flash and it's really uncomfortable. So there's a lot of other things factoring into this as well. If you have a BMI over 30, you're going to have an increased risk for all kinds of health issues down the line, but you're also going to have more hot flushes and night sweats because the higher BMI creates a little bit of insulation. So the higher your BMI is, the more we want to try to get that under control. When you start on hormone therapy, it does not make you drop 20 pounds. I wish. I wish, that I could give you estrogen and progesterone and you drop 20 pounds. It doesn't do that. It won't make you gain 20 pounds, though, either. It has small but measurable impact on lean body mass and that visceral fat, that belly fat. So it's going to shift you a little bit more toward muscle. It's going to shift you a little bit away from the visceral fat, but not, it's not going to be like, whoa, all of a sudden. It has little impacts, but it's certainly not going to make you gain more weight. And then if you start transdermal estradiol, you're certainly going to have some benefits in terms of lower risk of heart disease, et cetera. And we can talk about weight gain and how to manage it in the Q&A if you want to talk about that. What about the brain? People come to me and they say, my mother had dementia, my grandmother had dementia. It terrifies me. If I take hormone therapy, is that going to protect my brain? Well, what do we know about that? Well, we know that hot flushes and the brain definitely interact. And the worse a woman's hot flushes, the worse her memory is. Verbal memory correlates to hot flushes. It's very interesting. And when we treat to improve the hot flushes, verbal memory improves. So that brain fog lifts a little bit, and you tend to get a little bit of benefit in terms of memory. The other thing that happens when we treat hot flushes is Alzheimer's markers in the blood change and they decrease when we treat hot flushes. Super interesting. We don't know why that is, but the hot flushes are associated with these kind of changes. And so if somebody says to me, yeah, my hot flushes are terrible, but nobody ever died from hot flushes, I think I'll just wait it out. Then I say, well, are you having brain fog? Because the brain fog might get better if we treat your hot flushes. But so having said all that, we don't know yet if hormone therapy actually prevents dementia. We don't have data to support that. There's a lot of research going on. What we do know does help to prevent dementia are lifestyle things. Moderating your alcohol intake, don't smoke, eat mostly a whole food plant-based diet, get your exercise minutes in, manage any chronic conditions. So if you have high blood pressure, get that dealt with. If you're pre-diabetic, get that dealt with. You know, all of these things are super important. Heart health is brain health. So everything we do for a healthier heart helps our brain as well. And then connection to our families and friends and community really protect our brain. So if you have a good friend that you could call at 3 a.m. if you needed something, your brain is benefiting from that. So maybe you text that person today and you just say, hey, you know, I love you, I miss you. I can't wait till we get together again. That's helping your heart, that's helping your brain. I want to finish up with some stuff about bone and just some final take-home messages, and then we'll switch over to the Q&A. So bone health is critical for healthy aging. It is absolutely critical because you fall, you break a hip in your elderly years, it is a complete disaster. 1 in 4 women who fall and break a hip will die, and another 1 in 4 will be permanently disabled. So just my own mother's situation, she had osteoporosis and she was living independently in her retirement community, and she fell and broke a hip, and within a year she had gone into memory care. Her dementia progressed rapidly, and within a year and a half she died. And this happens over and over and over again in our elderly years. We are going to live to be 90 or 100, and our bone health is super important for this because when you fall and break a hip, everything starts deteriorating. So what do we know about midlife bone health and how to preserve it? So first thing we know is that men and women both lose bone mass as they age, but men start with more than women do, and women have an accelerated loss once they hit menopause. So you can see here with this graph at around age 50, all of a sudden, boom, you know, you start losing. And then the rate of loss slows down, you continue to lose, but you're already down quite a bit lower. And so you're much more at risk for fractures as you age. Of the 10 million women or 10 million Americans who have osteoporosis, 80% of them are women. For this reason, because we start with less and then we have that accelerated loss at the time of menopause. We lose up to 20% of our bone mass in the first 5 years after menopause. So the guidelines about bone density scanning, DEXA scanning, are changing. It used to be that we would get a DEXA scan at age 65. And, you know, going back to this, look at this. If you get a bone density scan at 65, you know, the jig is up already. You've already lost all that bone mass. So the guidelines are shifting now. Guidelines still say to get it at age 65, but that's going to change. And I'm getting them at the time of menopause on my patients, and they almost always are covered by insurance. And so please do ask your provider for a bone density scan. And if they say, well, you're not 65 yet, then just say, I still want to get it. I still want to get it. And chances are you will be able to do that. And then you will know, because I am diagnosing a lot of osteoporosis in my 50 to 55-year-old patients. Treatment with hormone therapy arrests that loss and it bumps it by 5 to 6%. So when you start on hormone therapy, at whatever point, again, on this curve you are, you will stop this loss, and it will stop and it will stabilize wherever you are and give you a little bit of a boost. So hormone therapy is indicated for people at high risk for osteoporosis. And when you stop the hormone therapy, the bone loss starts up again. So that's why there's no age that we automatically stop hormone therapy, because you will see that accelerated decline in the bone again whenever you stop it. Calcium, 1,200 milligrams a day, no more than 500 in a supplement, because any more than that will tend to deposit in your coronary arteries in your heart, and we don't want that. So the majority of it should be in your diet, and about 500 to 600 in a supplement. About 2,000 international units per day of vitamin D will also support bone health. And strength training. Strength training. You have to lift weights and you have to lift heavy. Again, yoga and Pilates are great for core strength, but for muscles and bones, you want to be lifting weight. People ask me about creatine, and the way I think about the impact on the muscle and the bone is the strength training is the cupcake. Protein intake is the frosting on the cupcake, and creatine are the sprinkles on the frosting. So that's the relative effect size. Strength training is by far the most important, and then protein intake, and then creatine. So that's really key for preventing osteoporosis and preserving muscle mass. This may all sound horrible. And when I lecture at the medical school, the medical students are just like, what? This sounds awful. But I want to emphasize that all of this is manageable. Perimenopause is the time when the symptoms are the most challenging. But when people are through it on the other side, there is a thing called menopausal zest, which is real. And most people in their late 50s, early 60s would not go back and be 35 again for anything. I did a podcast with The Atlantic recently called How to Age Up, and their tagline on it was how to wish you were 65 instead of 35, because there is this thing called menopausal zest. And when we get through it, we're happier in all those aspects of our lives. So you do have that to look forward to. I want to just shout out to the Menopause Collaborative of Practice. These are the folks at Stanford who are the leaders in women's heart health, bone health, brain health, cancer survivorship, mental health, sleep, etc. Just a wonderful, wonderful group of folks to collaborate with. We also have 5 menopause experts in our women's health clinic. We also have, as a Stanford employee benefit, access to MIDI Health, which is a telehealth menopause platform. So we have a lot of resources there. Please do follow us on our Instagram at Stanford Menopause. We post things that we think are useful for our community. And then we are sponsoring, the Menopause Collaborative of Practice is sponsoring the 2nd annual conference in menopause and healthy aging in February. This is designed for providers. So if there are any providers on this call, feel free to join and learn in depth, 2.5 days, about all the things I've talked about. If you're not a provider, do stay tuned, because we are going to be sponsoring a menopause and healthy aging conference for people, just people. And we're going to have a focus on lifestyle medicine as well as hormones and non-hormonal therapy. So we're hoping to do that this fall. With that, I will stop and thank you all so much, and we'll switch over to the Q&A.
Thank you so much, Dr. Adams. And I just want a quick reminder for everyone that menopause is real. We should all just add that to our daily affirmations and just keep repeating
Right,
it. So
right.
let's get through some of these questions. There was a lot submitted, so let's just dive in because, like I said, there's a lot from all sorts of subjects. Uh,
Christina, I have to tell you, I think moderating is by far harder than giving the talk. So, and I know you've been working through this whole hour, so yeah, I bow to you for that.
No, thank you. Okay, so the first one that I think is pretty important is about how women sometimes stop reporting symptoms because PCPs may brush them off. How do we get more doctors to encourage reporting of symptoms, and how can we get around the hurdles to get actual treatment?
Oh my goodness, that's the question. That's the overarching question. You know, the issue is the Women's Health Initiative data came out in 2002, saying that hormone therapy increased the risk of heart attacks and stroke and breast cancer and all these things. And so for 15 years, providers weren't trained and they were just told, no, we're not giving that. So, you know, just tell people to tough it out. And now the pendulum has really swung, and we know there's a nice window of time to start hormones where you do get the benefits. And we're scrambling to train all the providers who are now seeing patients and don't know how to assess it, how to treat it, how to talk to people about it. So we're working very hard. The Menopause Society nationally just was given $10 million with a goal toward training 25,000 providers in the next 3 years. So hang in there. We think the landscape is going to get a lot better in the next couple of years because we're all out here really trying to teach the people who are seeing you. I guess what I would say is I would say, to them, you know what? Yes, I'm still having periods, but these symptoms are, I know they are related to perimenopause, and I know that hormone therapy can help. And so I would say advocating for yourself is number one, and just saying, I understand that you don't think I'm in perimenopause, but I know that I am, even if my periods are regular, because I'm at the right age and I've got the list of symptoms. So it's age related, it's symptom related. Look for a Menopause Society certified practitioner. So if you go to the Menopause Society website, and it's just menopause.org, there is a little place where you can put in your zip code, and a whole bunch of certified menopause providers will come up in your area. And you can see somebody who's actually has more expertise in it. So that would be your two resources. One is advocate for yourself. The other is look for a certified menopause provider.
Excellent. And I know it's very important. So, I also wanted to cover a topic that I don't believe I heard come up in the talk, which is IVF. There was a few questions on whether IVF or other fertility treatments that use hormones cause menopause to start sooner, or what the effects are of if you have had IVF or another hormonal treatment early in life, and how that impacts perimenopause and menopause.
Right. It does not. IVF does not make menopause happen earlier or more dramatically or anything like that. The definition of premature menopause is menopause before age 40, and early menopause is menopause between the ages of 40 and 45. So those are very specific medical terms that we use. Early menopause between the ages of 40 and 45, premature before the ages of 40. And those can happen because of chromosomal things that people might have, that can happen because of autoimmune conditions. It can happen because of genetics. It can happen because of cancer treatments, but not IVF. IVF does not cause premature or early menopause.
Thank you.
Mhm.
And then another hot topic that came in through the questions was regarding weight gain drugs or weight loss drugs, and if
Yeah.
that is a good way to deal with weight loss due or weight gain due to menopause.
Right. The GLP-1s are those injectable weight loss drugs. The early generations of them were Wegovy and Ozempic. Now we tend to use tirzepatide, which is known as Zepbound, because the weight loss is the greatest with that particular form. These drugs have really been game changers for weight management in menopause and really for everyone. When people go on them, their lipids get better, their prediabetes it gets better controlled. Often people's diabetes meds can be changed or stopped completely. So they're great for chronic illness as well as weight loss, just weight management in people who don't have those chronic conditions. The only people who should not take GLP-1s are people who have kind of a rare type of thyroid cancer, medullary thyroid cancer, or people who have liver or renal failure. In general, they work very well. They are indicated for people who have a BMI over 30, class 1 obesity, or people with a BMI over 27 with what's called a comorbidity, meaning sleep apnea, hypertension, prediabetes, something that may be weight related. Some people are using them off label for just weight gain in menopause where you don't meet those criteria. But if you meet those criteria, then your insurance likely, fingers crossed, will cover it, with some major exceptions. Kaisers, I think, in general, don't cover them very well, but that's changing. If you do it off insurance, if you pay for it out of pocket because your insurance won't cover it, there is a website that the Lilly company that makes Zepbound has made available that providers can order it through that. And then you get a text on your phone with a link that you then click and you put your credit card in, and then they send it to you in the mail. And the lowest dose costs $399 a month, which is a little bit better than what CVS would charge you. And then the higher doses are $499 a month. So again, a little bit better. So if you want to do it off label and your insurance doesn't cover it, then you can talk to your provider about doing it through the online portal. Things to watch when you're on that medication: it slows gastric emptying, so you feel fuller longer. And it also hits the centers of the brain to take away some of the food noise, so you're not feeling as hungry as you otherwise would. So because you're not hungry and you're not eating as much, you have to push fluids like crazy because you can get dehydrated. So you want to push fluids like crazy. And then the other thing is 40% of any weight loss on those drugs is muscle mass. And so you're going to lose muscle mass, so you have to strength train. So all of those things are things to consider, but you can certainly talk to your PCP or your provider about it. We actually are using them quite a lot, and they have been really, really successful combined with the nutrition and the exercise prescriptions that we always give.
Great, thanks. So we're getting close to that 1 o'clock, and there was several questions on hormone therapy. So I will dive into those, starting with a common thought or yeah, thought is that hormone therapy could increase the risk of cancer. Is that true?
Right. Oh, and I didn't say much about breast cancer. I should add that to this talk. Thanks for that question. So the risk of breast cancer is nuanced, and the risk of breast cancer with hormone therapy is different if you have a uterus, versus if you do not have a uterus, because the hormone therapy is different. So if you've had a hysterectomy and you're on estrogen alone, you do not have an increased risk of breast cancer on hormone therapy at all. Let me say that again. If you are on estrogen alone, you've had a hysterectomy, you can take estrogen with no increase in breast cancer risk. In fact, it's a little bit protective. So we'll set that aside. If you have a uterus and you are on estrogen and progesterone, you have a small increased risk of breast cancer. It's about 8 extra cases per 10,000 women per year. And you think about 10,000 women, that's like half a football stadium. 8 extra cases is not that much. 8 extra cases per 10,000 women per year. The risk of breast cancer is greater with a sedentary lifestyle, if you don't exercise, if you drink 1 glass of wine a night, or if you're obese. If you have class 1 obesity, it increases your risk of breast cancer by 9-fold. So yes, there is a small increased risk of breast cancer with hormone therapy, but it's quite a bit less than other risks that we don't really even think about. So keep it in perspective. It's always a risk-benefit balance when you're thinking about starting hormone therapy.
Great, thank you.
Mhm.
Um, is there a benefit or difference to take estrogen in the form of suppositories versus the vagina to combat dryness?
Right. So the vagina loves estrogen, and I didn't spend a lot of time talking about that. When you're on hormone therapy, you get about 80% benefit in the vagina. About 20% of people in my practice who are on hormone therapy still need some additional estrogen in the vagina. And you can do that with a cream that you apply to the opening of the vagina. You can put a tablet inside the vagina, or cream up inside, or a ring, or a suppository. So there are a lot of different methods. And what that typically does is thickens the tissue. So the lining of the vagina gets thicker. And so when you go through menopause, about 50% of people have pain with sexual activity. About 50% don't. I have a patient who's 80 years old. She's having sex with 2 different men and no pain at all. And so you don't always have pain when you go through menopause with sex, but if you do, estrogen will fix it. And that's usually penetrative pain, so putting something inside the vagina. So yes, those tablets, the cream, that sort of thing can be very helpful, very effective, and you can use it even if you have breast cancer because it does not absorb into the bloodstream the way the patch does. So the local forms of the cream and the tablets you can use even if you're on that list of conditions that are contraindications. We do not recommend compounded hormones. We don't recommend pellets. We don't recommend anything other than the bioidentical forms that are FDA approved, meaning the patch and the pill and the ring, those sorts of things. Pellets can give you very high levels that are not always safe, and compounding can vary from batch to batch to batch, so we're never sure what you're getting. So we don't recommend compounded. We don't recommend pellets.
Great, thank you. Are there any non-hormone treatments for perimenopause or menopause symptoms, dryness, hot flashes, anything that you recommend?
Mm-hmm. Yeah, non-hormonal treatments for perimenopause symptoms really are determined by what symptom is that we're treating. So if it's mood, for example, antidepressants. If it's sleep disturbance, it's cognitive behavior therapy for insomnia. If it's joint pain, it's exercise. If it's weight gain, it's exercise and plant-based diet approaches. So it really depends on what it is that we're treating. For hot flushes and night sweats, non-hormonal methods are the fezolinetant, the gabapentin, those kinds of things, not black cohosh or women's formulas that you buy off the shelf.
Great. Thank you so much. And like I said, we have so many questions. I wish we could go through all of them, but we're reaching 1 o'clock. So I just want to take this 1 minute to say thank you to everyone who joined and take the reminder to please take the questionnaire so that we could learn and improve from these webinars. And I want to say again, thank you, Dr. Adams, for taking the time to just share your knowledge on the subject and really
It's my
appreciate it. So
pleasure.
thank you.
Thank you for having me.
Everyone else, enjoy the rest of October and have a great Halloween. Have a good one.